deputy directors, director generals, ambassadors, if we have any, all protocols observed, you are most welcome to this Lancet series launch. We're going to begin now. By way of introduction, my name is Ade Adeyemi, and it is my pleasure to be moderating this session and guiding you through what will be a really interesting conversation. I see some familiar faces, so thanks for those of you that are coming back from yesterday's conversation, and welcome to those of you that are joining us for the first time. This session will officially launch the Lancet HIV and the Lancet Global Health Joint Series on Sustainable HIV Prevention in Africa, featuring insights from the editors and many of the contributing authors. We had a quick rundown of some of the papers yesterday, and this will be a further foray into it. I think my reading list is definitely long right now. Just some thoughts to frame the conversation before I invite Peter, the editor-in-chief of the Lancet HIV, and Zoe, who might be joining us virtually. So, despite remarkable gains in the HIV response, Sub-Saharan Africa still accounted for 60% of new HIV infections in 2024, underscoring the persistent prevention gaps. As more HIV programs face disruption due to funding uncertainty, this Lancet HIV and the Lancet Global Health Joint Series, co-authored by more than 24 experts from across Africa and the globe, offers practical, evidence-based strategies for strengthening health systems' capacity for sustainable HIV prevention while advancing broader health system goals. Let me just sidetrack from that a minute. The thing that I love most is the practical, evidence-based. So by way of introduction, I currently work for the Department of Health in the UK, advising our Secretary of State and ministers. And I also have a background in academia and research, and one of my biggest gripes is that gap between the research and actually then what ministers in action do. Ministers who are faced with constituents, taxpayers, other demands on their time, and politics with a big capital P. And not many of us understand that and can speak that language. What I've heard from this conversation so far has been really encouraging because it's actually evidence-based, it's practical, it's things that can work for multinational and national governments. So I hope that we keep that energy going, we keep that journey going. So let me continue. The series explores themes such as systemic integration of HIV prevention into public health systems, systemic community engagement. Again, community, really important, constituents, people. If you don't bring people along, it won't work, it won't be adopted, and it won't have political salience, it won't have political currency. And leveraging digital health and artificial intelligence to expand reach and improve program efficiency. All very important stuff, all stuff that I think most of us are familiar with. I didn't have a background in HIV, so I'm an imposter here, and I'm learning, and I'm really encouraged by all of what you're saying. So, well, I'm going to invite the editor-in-chief of the Lancet HIV, and I think the technology is working, as Zoe's going to join us virtually. She is the editor-in-chief of the Lancet Global Health. Let's encourage our speakers, so give them a warm welcome as they make their way to the stage, please. Keep the applause going. It's a bit of a long walk, so keep the applause going, please. Thank you, Peter. You're welcome.
Thank you very much. Thank you. Thank you very much for the very warm reception. Thank you also for the opportunity to contribute to this really important session, and a huge thank you to all the authors who contributed to the series. It's really a fantastic piece of work, pulled together in sort of difficult and slightly tumultuous circumstances, but I think it really has it's really something you can all be very proud of. And particularly, I'd like to say a very special thank you to Charles, to Betha and Mumbi for bringing together the Sustainable Prevention Initiative and leading on this work. So thank you. When Charles first approached us with the idea for this series in 2024, a series about sustainable HIV prevention, I thought, great, this is just what we need. There's long been talk about over-reliance on donor funding and problems with siloed approaches to HIV programs and having different bits of programs sort of siloed and fragmented, and how that's inefficient and can be wasteful. And also with the introduction of new products, long-acting interventions, dapivirine rings, and added to the milieu, meaning that really there's finally a great amount of choice for people who want HIV prevention. This is the perfect time to be doing this series. It's going to bring together some innovative thinking and experience from across a whole range of countries and communities and settings that's really going to help set a course for the next maybe 5 to 10 years as people really build sustainable, integrated HIV prevention. But then, obviously, January 2025 happened, and instead of having a perhaps 5 to 10 year roadmap for a transition to sustainable prevention, the need was incredibly urgent. These gaps that I thought the series would address weren't something that could be worked on over time. The gaps were just here, now, and having measurable, demonstrable impact on communities, on service providers, at that very moment. So really it became an essential project, I thought at the time. But at the same time, with that changing, with that seismic change in the context of the series, I really thought the idea that we initially had of launching the series at ICASA, at this conference, was going to be something very difficult to achieve, given the rethinking that might be required with the changing context. But after a meeting in Longway in February, where a lot of people were reacting to the events of January, and really sort of just coming to terms with that, the authors realised the importance of delivering this series now, and have really pulled out all the stops to deliver this important series. And I'm really pleased with the product that we have, in that it does these things. It does address the issues of introducing new products. It does address how to reimagine systems to introduce new products, involving communities, working with service providers, so that there's not such a great reliance on external funders, and so that things can be introduced fairly and equitably. So I really think that, remarkably, the gaps that I thought this series was going to fill, the questions that I thought it would address, it has done in a really short amount of time, in a tumultuous time. And yeah, so I think I'll say it again, just an incredibly great project. And just finally, my final thoughts are, what I really hope people who are looking at the series, who are reading the series and digesting the series, take from it, is that now is a time to act, now is a time to take on board the series and really challenge your ways of thinking. We can't go on doing things the way we have done them, but you've got to look at the series, look at the recommendations, recognise the huge amount of thought and insight that is presented in the series from the examples given, and really open your mind to new possibilities, have discussions, reach out to authors and contributors and people working in the programs that are given as examples, and try to learn from each other as you build going forward, building back something different, sustainable, equitable. And the other key message, I think, is really, as we say so many times, engage with communities. You cannot achieve anything in HIV without bringing the communities with you, without letting the communities lead, without, whenever you want to do something, approach the communities at the start, see what they need, see what is going to bring them along with you, and acknowledge the contribution of communities and reward the contribution of communities. And that's all I'd really like to say. So thank you very much for giving me this time, and yeah, thank you.
Thank you very much, Peter. If you could have a seat, we might come to you in a moment. I've got some snazzy technology here, which I think is going to allow us to link Zoe in. Just going to see if the tech is going to work. Also, just a plug to people watching virtually, I have something here where I can see your questions. So if you do want to contribute virtually, please do type in the chat, and I can see it here and bring it into the conversation. We're just going to give it 30 seconds and see if Zoe can come in.
Anyone hear me yet?
Oh, we heard her and we saw her briefly.
We heard her and we saw her briefly.
And there's some echo. Zoe, can you hear us? Oh, I saw your mouth move, so I think you can hear us. We can see you in the room. We can't hear you yet, so we're just going to wait for everything to align and work perfectly. Whilst we're waiting, let me just say I'm really jealous, by the way. In my specialism, I don't have anything like this series where everything and all the lessons learned and recommendations are so easily laid out for you. So I hope you really do take the time to read through the series and absorb all that knowledge. Let's try one more time. Zoe, can we hear you? Can you hear us? No. Okay, we're going to try again. Peter, if you could grab a microphone. I did have one question for you. We had Dr. Landry yesterday, who is the director for the Centre on Primary Healthcare from the Africa CDC. In a lot of what you were saying, I didn't quite hear your thoughts on integration with primary health centres and where that comes up in these series, or if you could share your view. Thank you.
Yes. Well, this is something that I think Zoe was probably going to speak about a bit more. So I think, I mean, really, there's so many opportunities for integration across different health interventions. So within primary care, giving people, having discussions about HIV within primary care, but that really requires a lot of work in enabling and empowering primary care providers to have those conversations. There's big issues around, stigma and discrimination that need to be tackled to enable integration of HIV care into primary care and other healthcare settings. But it really is achievable. I mean, there are lots of examples of it happening. I think it's paper 2 in the series that tackles this issue, and it is addressed elsewhere in the series. So I mean, there's so many opportunities. People are accessing healthcare for many different reasons, and if we can just open up conversations about HIV within those settings, there's a huge opportunity to improve efficiency and sustainability.
Thank you. Please stay here on our shared microphone. Let me just try one more time with Zoe. Hello, Zoe, can you hear us? If not, I've got another filler question for Peter, which is, for people in the room that weren't authors and people like me who are jealous and would like to be published in the Lancet, what are the routes, what are the avenues open for people to publish, to write, to find other authors to contribute with?
I mean, we are contactable through the Lancet, and we are always open to your great ideas for series and projects and papers. We would very much welcome reflections on this series. There are opportunities to write comments or correspondence that you could submit to our journals. We like to think that we are, a vessels for exchanging ideas, for conveying ideas, for helping people relate their messages, for helping people to hone their messages. And so we're very, very open to that, and we really welcome. We don't ever want to publish something and that be the end of the discussion about it. We want things we publish to start discussions, to inspire new thoughts, to inspire new ideas, and we're always ecstatic to hear more about those. So if you do have any reactions to the series, then you can reach out to us through our correspondence section, for example, or reach out to us as editors. And we're always open to ideas for projects. We can't always do everything, but we are very keen to hear your ideas, and we'll always try and find some way of working with people.
Thank you very much. I have no more filler questions for you, Peter, so I really hope that this works this time. Can we try one more time hearing Zoe in the room? Zoe, can you hear us? Can you?
Sorry. Hello, can you hear me now?
We can hear you. There's a small delay. I think we also do have a recorded video of you, but we'll keep trying with this. Whilst we can actually hear you, please, yes, introduce yourself and your reflections. Oh, I spoke so
Now I
long.
can't hear you.
Yeah, hopefully the tech team can figure this out. If not, I hope the tech team can play the backup video and we can try hear from her later. Sorry, ladies and gentlemen, please bear with us. Zoe, please try again and just continue speaking if you can hear.
Okay.
Yes, go.
Dana says you can hear me, so I can't hear you, but I'm just going to speak. So hopefully I'm not talking over the top of anybody else. But I was asked to speak a little bit on the integration into primary care and the wider health system. And I think from my perspective of someone who's sort of coming from the global health community more than the HIV community, the idea that HIV prevention should be an integral component of wider national efforts towards primary prevention and a sort of life course approach to healthcare is a bit of a no-brainer, really. So what I think the series does, particularly paper 2, as Peter said, is to make the case to the HIV community that there's really nothing to lose and everything to gain by considering that the key facets of HIV prevention, so things like prioritizing and tailoring services, demand generation, quality and accessible delivery, and support for the sustained use of prevention products, actually map very neatly onto public health frameworks and therefore onto wider primary health care. So what I particularly like about the series approach is, as also I think Peter alluded to, is the judicious use of real country examples to make the case for how the really challenging shifts that are going to be needed in governance, financing and leadership could be achieved in different contexts. And finally, I think it makes a really strong case for the terrible wasteful nature of fragmented, overlapping and uncoordinated vertical programs in this era, as Peter mentioned again, of these drastically reduced external funding. So HIV needs to be brought under the auspices of national health systems or risk the loss of essential services, of accountability and resilience as this donor money evaporates. So I'll leave it there. I think maybe, hopefully you can still hear me. I've lost you, but thank you for having me. I'm sorry I can't be there in person.
No worries, we can hear you and hopefully you can hear me because I did have a follow-up question. If you could just nod if you could hear me. Oh, thumbs up. Okay, I think so. Yeah. Okay. So my follow-up question is around the gender equity in this program. I think there's a great gender balance. We also know that women make up 70% of the workforce in global health, but occupy less than 30% of the leadership positions. When it comes to women leading research and leading and authoring papers, what's your view on how that could be improved? Are you hearing me? I'll stop there if you can speak on that topic. Oh, she can't hear me. Okay, no. All right, no worries. Let's give a big round of applause for Zoe and Peter. Thank you so much. Thank you. Okay, that did work, thankfully. Okay, let's move on to hear from some of the contributing authors. Let me read out their names and titles, and then they'll all come to the stage together. We have a really interesting panel here. And again, let me invite you in the room and those virtually to think up questions, think up reflections. I want to make this as interactive and intimate as possible. So we'll come into the stage will be Professor Kenneth Ngure, who is the IAS President-elect. We will also be welcoming Ms. Hasina Subadir from the South African National Department of Health, Dr. Beatrice Matenje from the Malawi National AIDS Commission, and Dr. Charles Holmes from the Centre for Innovation in Global Health, Georgetown University. A big round of applause for all our panelists, please. Keep the applause going for them. It's a big walk to the stage. Thank you. First, let's just check that all the microphones are working. Hello? Hello? Any of your microphones working? No?
No, is it working now?
The microphones aren't working yet, or else we're going to get our steps in for the day, getting up and down to this. Okay. Hello? Yes,
hello?
we're there.
Perfect.
Charles, could I just check yours works as well?
1, 2, 3.
1, 2, 3. Okay, great. First of all, how are you all feeling now that it's done? I think there's been a long journey back round to this. Let's just check in first. How are you feeling? We'll start from Kenneth and work our way down.
I think I'm excited. Good morning, everyone. Great to see you all. I'm quite excited. Like any paper, we get excited when it's out, but this is a special paper that is coming out in a timely way. It's coming out when it's most needed. So very excited to see the science out. And thank you, Peter.
It's really exciting to reach this far. As Peter said, we started discussing this series from last year, 2024. And as I said yesterday, for those that were here, this was before the January 2025 shock happened, but we had already planned a series on sustainable prevention. So to reach this far and the coordinating and the primary authoring here and there, senior authoring here and here, a myriad of authors, coordinating all of them has not been easy, but it's been really a great time. Thanks to Georgetown for coordinating, Betha specifically, Dana, for being there, putting all the thoughts together. Some of us were just there to, you know, to give guidance, to give inputs, but putting everyone's thoughts and comments together is a lot of work. So thanks to Georgetown, and I'm excited that we can have the world read all the 6 papers today. Thank you.
Hi, good morning. I'm very excited, especially given that the launch of the series is coinciding as we, the early adopter countries for lenacapavir, are preparing to roll out the first long-acting injectable in many of the countries. So I do think that this is a very timely publication, and many countries will benefit from the value that this publication brings. So thank you very much. And thank you to Charles and Betha for all of the guidance and leadership on the putting together of the series. Thank you.
Thank you so much, Ade, and everyone who's spoken, and I would just thank you in return. The partnership has been tremendous. We were really able to draw upon some of the best thinking around governments, civil society, and NGOs in a way that I think was quite unique. I've been involved in a lot of such projects over the years, but this felt a little bit more like a movement, and a movement that was really growing out of a lot of the learning that we've had over the years about, gosh, it seems funny that we're over here doing this HIV response when there's this broader health system. Mustn't there be some ways that we can innovate, bring things more closely together while respecting the need for specific pathways for vulnerable populations who may need special care? So for me, it's really the culmination of a movement of sorts, and I'm really, couldn't have chosen a better group of people to be in the movement with. So again, thank you to Beatrice, thank you to Mumbi Chola, to Betha Igbenosin, and in particular, I'd like to thank Peter Hayward as well as Zoe Mullan for an incredibly supportive editorial engagement and process with us. So thank you again.
Thank you all. Round of applause for everyone contributing there. Let's get a bit technical now. Let me start with you, Charles, if I may. what is one strategic shift global partners should make in how they invest to help countries, particularly to reinforce these functions for more effective HIV prevention?
Thanks. I think it's hard to choose, but maybe I'll kind of go broad with a bit of an overarching insight. And I think it really derives from this idea that Zoe mentioned, as well as Peter, that there are more commonalities than not between HIV prevention and general wellness and health. And so as you look at paper 2 and go into detail there and see the overlap in terms of the frameworks that really, prevention's all about targeting, tailoring services to people, raising demand, meeting them where they are, and we often are reinventing the wheel, whether it's a new drug and we think, wow, we need new fancy pilots to do this or that, when in essence, in the background, primary care is plugging along and doing many of those functions, not always that well. The primary health care system itself is underfunded in general, in almost every country, but certainly in the region here. But that doesn't mean the ideas aren't right and the functions aren't there. And so I think the fundamental shift is really to try and embrace and align more with those core functions, to utilize some of the best technology that's available that's going to leapfrog us. I think about the digital health paper that Gerard Radivosian was so engaged with, and the way in which AI is going to help not only HIV, but it's going to help primary health care become more effective in meeting people's needs. So let's recognize those shifts, let's come closer together, and countries are in the lead. Where I'm a little bit less sure is whether funders, bilateral or multilateral, are going to be able to meet this moment and support countries in their journey. So I think that's the fundamental shift we need to see. Thanks.
Okay, one other question, and let me push you here a little bit. So for some of our global north partners, Western funders, particularly the bilateral ones, we see an unfortunate, in my opinion, rise of far-right rhetoric and those countries wanting to look a bit more inward. What's your message to those political leaders in those administrations where they're saying, actually, we need to put our country first? We can't think about those problems over there.
Well, I think the obvious response is that we're all affected by the health of others. We've found over the years, over the last 25 years of the HIV response, for instance, where there has been such solidarity, where there has been such generosity, where there has been such openness and opening doors of diplomacy through health, I think we have learned that the benefits to donors, particularly bilateral donors, are not just sort of keeping our shores safe. I suppose that's an element to it, with infectious diseases. An infection anywhere is an infection elsewhere. But really more compelling to me is that the world is safer if we have healthy populations, if we have people who are able to be productive and meet their potential. And so while that may seem rather lofty, I think national security for any bilateral is informed by the health and the well-being of the world. So if you have a healthy region, there's going to be less conflict, there's going to be less economic challenge, and that means you have new trading partners, that means you have allies in other fora. So I think that's what I would say to them at this moment.
Maybe you need a meeting with RFK to say that directly, but I'll leave that for a private conversation.
I'll turn my mic off at this point.
I'll turn the mic off. That's safe. Haseen, if I can move on to you. From your experience and the insights presented in the series, which system enablers are most critical for ensuring that new HIV prevention products can be introduced efficiently, equitably, and at scale within primary healthcare systems?
Thank you for that question.
Oh, I think you need to...
Can you hear me now? Yeah, okay. So I think what the series does highlight, and from our experience in South Africa, is that for a successful scale-up of any HIV, biomedical HIV production, any product, we require systems that allow it to be scaled up. And I want to highlight 5 of the absolutely critical systems that we found that needed to be in place to support the implementation. The regulatory and policy pathways, having our country regulators, and we know that medicines are highly regulated. And if we do not have a regulatory pathway for that particular product, we cannot roll it out and scale it up adequately. Also making sure that these are not bottlenecks, that it becomes, and it happens very soon, shortly after the clinical trials show evidence that something works, to actually make sure that the regulatory pathway follows that. And at the same time, having a pathway for making sure that the policies that are required, the tools that are required for implementation, the systems that are required in your health system to implement something is also enabled. And this needs to
actually follows through.
Thank you, Eddie. Briefly, let me say that there's need for governments to institutionalize the role of communities as not only implementers or advocates. I think this time around the communities have become more of advocacy agents, but they should be institutionalized as the co-designers of the programming as well as accountability agents. So talking more about accountability agents, community-led monitoring, as we all know it, is such a powerful mechanism that should not be, unfortunately, it's more of donor dependent. Most of the community-led monitoring initiatives are donorly funded, depending on donors, and when the pull out or the stop work order or the executive orders came, we found most of them, in those initiatives, almost dying down. So in this series, we are calling upon governments to institutionalize the role of communities as accountability agents, to make sure that the community-led monitoring is a core part of the sustainable HIV as well as broader health programming. And how can communities be empowered to do this? Yes, it could be legislated or a policy that they should be accountability agents, but without any resources, it's difficult. So we're also calling upon governments to basically develop or legislate policies that support social contracting. One of the papers is asking, or especially the one for systematic community engagement, is asking for social contracting so that there would be an allowance for public financing of the CSOs through local grants. And we know it's not easy, especially if a government cannot meet all the needs, or especially treatment needs. To think of putting money towards prevention through a social contracting mechanism, it can be daunting. But what I would say is that what we are calling for is a systematic way to think of this as a possible thing. Some countries, we have examples of Zimbabwe through the AIDS levy, we have Namibia, we have Uganda. There are countries that are already implementing social contracting. And if all governments can consider a way, it doesn't have to be one size fits all. If a particular government can fund all the social contracting needs from the government pockets, so be it. But for other countries like mine, Malawi, where the competing needs are so much that we cannot ask 100% of the social contracting funds to come from government, this is where private financing comes in. We have the private sector, we have other development partners, the Gates and others, I always mention them, the philanthropists that are out there. How can they support the CSOs? Instead of going directly to the civil society organizations and losing out on accountability to governments, why not give that money through government, have a basket where the government mechanism can manage and support CSOs in a social contracting way. And what we're asking for is results-based financing. We are not just asking for putting money for the sake of putting money, but having common goals that are within the national strategic plans for HIV and broader health systems, and also to make sure that this is monitored and not all NGOs can think of, or let's say there are thousands of them receiving money, but rather using proper mechanisms. That's why there has to be a policy on how to implement that. So tackling these issues, public financing, as well as institutionalizing community-led monitoring would help the communities to be embedded within the system and not just be additional or ad hoc supporters. Thank you.
Hello? Yeah, there we go. I've got a follow-up question, if I may, and just conscious of time, so I want to make sure we get through everyone before we invite questions from the audience. As I've said many times, I'm quite naive in this area, but when I think ideologically and conceptually about a government funding a patient advocacy group or some kind of group, there is always a conflict of interest, and it feels, from my understanding of history, like a slippery slope to aligned interests which the independent group can't do because they're not independent. Are my concerns valid? Because if I heard what you said correctly, you said that governments should be looking at mechanisms to fund patient groups or civil society. Are there safeguards you think we could put in place, or have I misunderstood the point?
Yes, your concerns are very valid, and that is the reason why up to now, not all governments are doing social contracting. From the beginning, the mechanism was introduced. Most governments were a bit skeptical to think of how can we give money to either an advocacy group or to groups that may just use the money and not really deliver much. So the safeguards, or the safeguard would be in, as I said, looking at your national strategic plans and goals. What services are supposed to be out there in the communities but government cannot reach there? What is it that cannot be reached by government? So it's more of service delivery, social contracting than advocacy social contracting. So they would support with service delivery because there are many civil society organizations that are doing service delivery, but their resources are donor dependent and USG dependent, if I may say it. So we are asking for governments to take over, support these civil society organizations, but with the clauses on efficiencies, because the civil society organizations have to also be accountable. The accountability is not only from governments, but they have to be accountable. Whatever little resources, whether from donors or from governments, efficiency is key, as well as making sure that they, and how can they meet this efficiency, making sure there's integration. You can't have one CSO doing malaria only, another HIV only, another vaccines. If it's in the same community, why not integrate the service delivery? So integration and digital innovations, I don't want to repeat what Charles said, digital innovations to help with tracking and monitoring. Rather than having humans going out there all over to collect data, why not have mobile health apps that can collect the data real time and also consolidate reports without having resources to go out physically to collect the data? Thank you.
Thank you so much. Colleagues, you are up next after I've asked my questions of Kenneth, so please think of your questions. If you were here yesterday as well, you'll know that I would prefer hearing from our ladies in the audience, just so we can have gender equity. And I'm comfortable with being awkward and silent about that until we do have someone stand up, so mark my words. Kenneth, we have a question here for you, and I think the preamble is important, so let me read it. The series calls for a decisive shift in how HIV prevention is organised, moving from fragmented vertical programs to integrated models. From your experience and the insights presented in the series, what systemic reform is most essential for advancing meaningful integration and achieving sustainable HIV prevention outcomes?
Thank you, Ade, and I hope everyone can hear me. So before I start, I want to start with a small story. Time check, December 4th, 2024. The HIV services are moving at a cruising altitude in our clinics in Africa. We have that fancy clinic at the corner where we have supported providers, providing ALT, providing PrEP, and things are moving smoothly. Then January happens. From our cruising altitude, we hit turbulence, and the plane or the services start dropping, and we don't know whether they are going to crash. You know what many clinics did is that they moved away because there were no providers. The providers went away. The people who are keeping data went away at that moment. And people started moving towards other places to get HIV services. These were family planning clinics. These were outpatient clinics because they were already there. As things were happening, the thousands of people who attend and get services on a daily basis went to get services, but there were no providers. So they had to go into these all other places to get their services. That is integration in practice at a clinic level. This was almost forced integration, and we have been discussing about integration for more than a decade, but this was forced by circumstances. So when we now answering your question, what is the key systematic change or reform that's required? I don't think it's one. I think there are various levels. What I've just highlighted is a service level integration, which is very important. But we need also to move from service level to governance. We need to think about governance. What is required? We need to have accompanying policies, and this we have highlighted eloquently in the paper. We need to have reporting systems that are also integrated. We need M&E structures that are well integrated. We need data systems that are also well integrated so that this integration can be sustainable. The other thing I want to highlight is also funding, and I know we may have some funders in the audience. I think funders have been used to funding disease programs, those vertical programs, but I think my co-presenters here, or panelists here, have eloquently said that when you work with vertical programs, that is fragmentation, there's a lot of wastage, and wastage goes not only in terms of time, but also goes in terms of money. So how are you going to use the Kenya shilling, the kwacha of Zambia, or another currency like the rand of South Africa, or the US dollar for that matter, if it's coming from the funder? How are you going to stretch it better if you do not have efficient systems? And efficient systems are only in place if the systems are integrated, and then you lose all that wastage. So we want to encourage the funders in the audience to move away from funding siloed programs and fund integrated health systems. And this will address many barriers. We have outlined 4 key barriers within our paper. We have outlined biomedical bias within the paper, where we look at integration, and as people look at more of treatment versus prevention. They think about HIV as treatment. The other key barrier we have highlighted in our paper is about institutional inertia. People want to stay in that fancy HIV clinic that is fragmented at the corner so that they can safeguard funding from donor X or donor Y. But I think we need to start moving away from that. The way our institutions, some of them are structured, is in a different way, where we have HIV services standing alone. And I know after yesterday, some people came after the presentation to talk about the need to still maintain those vertical programs. But what I also want to say, in our paper, as you read it, it's not a prescription. We have given several examples from various countries, either in Africa and some from outside Africa. But what we are saying and showing by those examples are options and frameworks that countries can leverage and learn from as they think about integrating their services. And we also, as we do all these nice things and we think about integration, we need to put protections for key populations so that key populations are not left behind, especially if integration leads to providing services in places that are vulnerable or put people at risk of stigma and those kind of things. So let's put in protections for those populations as we integrate services with a net goal of building sustainable services that are not subject to turbulence and specifically to changes in leadership in specific countries or donor priorities. So thank you.
Thank you very much. A round of applause for all our panelists here. Thank you. I think I'm just doing a time check to see how many questions I can ask of the audience. I think I can only ask one question, I'm afraid. And our lady there has shot up straight away. If we get the microphone to the lady in green with glasses, please. If you could share your name and any affiliations. The microphone is coming to you.
Thank you. Lady in green is Rosemary from UNFPA Eastern Southern Africa Regional Office. And thanks to the team. I think mine is a follow-up to the very last question. The shift from vertical to institutionalized programming is inevitable. And we are shifting from emergency mode programming for HIV, but we are still handling an emergency epidemic. And I want to understand from you and the papers you've written, what you think it means in terms of time for us to shift to what you envisage and actually deliver outcomes. HIV has been a blue-eyed kid, and we will attempt to look for it on this integrated and weak platform, if I can say. What are the short-term, medium-term, long-term kind of aspirations are you looking at to ensure that it is not lost as any other thing that is integrated, and ensure that we transition rapidly but surely?
I think one of the things is the paper is out, the discussion is happening, and many of people in the audience are actually policymakers in their own countries, and I hope by the end of this conference, they'll move back to their countries, being motivated to know that this is urgent, because we don't want in January, again, 2026, or 2027 for that matter, countries are faced with similar circumstances. And I know people, especially from the African region, saw these challenges firsthand. So these problems as people are struggling and wondering what to do. I'm not too sure any policy maker would want to do that, would want to see that for their citizens. So I'm hoping that based on what we have learned and learnings and cross-pollinations that we are having, seeing an example from there and seeing an example from South Africa on what they are doing, looking at Rwanda, for example, on their very strong community health worker program, looking at, so there are almost various examples from various countries. And I hope that countries will sit back after this conference and many other things, and I know others have been having these discussions even before this conference, to sort of shorten that time. And there are examples that people can borrow from.
Thank you very much. 1 minute, Beatrice, just because I'm short on time, please.
I wanted to add on that. So the question is pertinent. When do we think this can be achieved? I don't think there's one size fits all answer for all the countries. Each country will go and look at where are we. If there is no example for Malawi on social contracting, we have to think of how do we learn from those that are doing social contracting. If there are examples for integration, good examples from elsewhere. So just like he has said, it depends on each country where they are, but the call to action is we should all do something. Inaction will cost us a lot. Yesterday I presented the cost of inaction, including resurgence of the epidemic. Where we were reducing the infections, we may start seeing infections going up because we have not done much after this crisis. Thank you.
45 seconds, Charles.
Okay. Thanks very much, and very much agree. I guess the one thing that I would maybe add is you asked about how do we sort of prevent the slippage, potential slippage in terms of the outcomes that we care about within HIV. And I guess I've always thought that part of what has distinguished the HIV response has been the attention to data, the attention to outcomes and performance of programs. And I agree with you fully that we are at some risk of losing that as some of the fundamental data collection elements get removed from the system. Some of the large surveys that are conducted that we use to benchmark our progress, for instance. So I guess one thing that I would call for, and I think everyone has sort of mentioned it in some ways, is just the further integration of data systems so that we're able to bring some of that performance management to primary healthcare from HIV, but also to maintain what we have in HIV, that strength. And part of what makes that work then is the community accountability and activists and civil society holding governments, holding donors to account for the continued performance that, of course, we want to see and that we don't want to see slip. Thanks.
Thank you very much. I know people were itching to put their hands up. There is only one exit out here, so you can get the rest of the panel and ask them your questions after we close. Without being rude as well, I also do spot some people I think are from the youth conference yesterday. If you feel nervous, let me encourage you, please do reach out to people right here and then, now. I'm sure they would love to have a conversation and support you on your journey as well, so please do grab them out at the end. Let me bring us into land now and get some closing reflections. If I could first invite Dr. Mumbi from the African-led HIV Control Working Group. Let's give him a round of applause as he comes to the stage, please. Dr. Mumbi.
Thank you, Ade. Thanks, everyone. I think for me, it's essentially three things that I would like to reflect on from the past 2 days. The first thing is that HIV prevention still remains important to the HIV response, and we need to ensure that we do everything possible to, as we think about integrating HIV prevention, we still ensure that it remains prioritized and well funded, even as we rethink how we implement our prevention programs. The papers that we have published, as has been extensively discussed, cover various areas that we need to consider, and there are examples in those papers that show that it's being done across different countries, be it on the financing side, be it on the tools, digital tools, and so on, health education and the like. Everything is being done thus far, and the examples are existing in those papers, so please, let's read and ensure that we look at the lessons that are in those papers and see how we can scale up within our context. The third thing is just to challenge each and every one of us as we go back home. As Kenneth said, let's use these papers, let's use the information that is there. These are African lessons that we have been generated within our context, and there is leadership that is being shown by our countries and governments as far as integrating HIV prevention within our broader health systems, involving communities who, like we have heard, remain at the core and are essential for us to be able to achieve all that we set out to do as far as ensuring we have a healthy population. I think with those three things, I would like to thank everyone, and I'll hand back to Ade. Thank you.
Thank you very much. Please take a seat. We'll be taking a family photo in a moment, but thank you for keeping that brief. And last but not least, if I can ask for Dr. Jürgen Pillay to give us his closing remarks. He's the Director of HIV and TB Delivery at the Gates Foundation. Ladies and gentlemen, can we please give him a round of applause as he makes way to the stage.
Thanks very much, and so good morning to everyone. I had the privilege this morning of visiting a clinic, a polyclinic, called Adabraka, just not so far from the conference venue, because I wanted to see, whether all the things we're talking about are happening or can happen in a typical clinic. The good news, Charles, is that they have a wellness center. It's right next to the TB consulting room and the HIV consulting room. Now, TB and HIV consulting rooms are set apart, but there's a wellness clinic right next to it, which anyone can walk into, no appointments needed, and you can get anything from a breast exam to an HIV test, check your blood sugar levels, check your blood pressure, etc. So I think there are opportunities that people on the ground are seeing about how within their own context they can start thinking differently about prevention. And I don't mean HIV prevention only, I mean prevention. And I think that was a good example of, yes, of course, they have not fully integrated HIV and TB services, but they've already started thinking about prevention writ large. I'd like to congratulate Lancet for commissioning this series. Thank you very much. It's not only timely, I think it's very important that we do not take our foot off the prevention pedal. So thank you very much to Lancet. And of course, big thank you to the authors. This is truly an African production with African examples, and I think it shows really good African leadership. I want to make a plug for implementation science. There was a call for donors to do things differently, and I think donors can step up with an integrated way of doing implementation science. It's only through implementation science that we can know what works and what doesn't work. And I fully agree with Charles. I had a comment written in my short note here, Charles, about learning the lessons of these vertical programs, whether they're HIV, TB, or malaria. And I think the data use and looking at what we're achieving and what we're not achieving in a consistent way at all levels of the health system are critical. So we shouldn't be losing the advantages we have had from these vertical programs. When we integrated TB many years ago, and I was in the ministry at the time, we suddenly saw a huge dip in the outcomes from the TB program. Now, we do not want to see that with HIV. And I think the issue around key populations has been mentioned as well. So I want to make a plug for close monitoring of the integration process as well as the integration outcomes. I want to read, there was a very nice paper written in Lancet Global Health reflecting on, is there an African epistemology around implementation science? And I want to read just one section, two sentences from that paper. And I quote, implementation science requires a methodological transformation to capture the complex mechanisms that drive successful implementation in diverse contexts. Current approaches, and they were talking about largely northern implementation science methodologies, systematically overlook crucial relational and cultural dynamics, particularly in the African settings, where informal systems and community relationships often determine program success. And I think that's one thing I'd like us to leave with, the importance of understanding these relational issues, the importance of understanding power relations and power dynamics as well. So once again, let me thank the authors. I've encouraged Africa CDC, Dr. Lanley, to take the series to his meeting next week in Addis. He's meeting with health planners and financial managers from all over the continent. I've encouraged Nduku and the leadership of the NACs, the National AIDS Councils, to take the series into their next meeting. And I'll also encourage the Global HIV Prevention Coalition to do the same. So I think there are avenues for us to, in a very intentional way, use the insights from these papers. And I think we have to hold people accountable, given the hard work that these people put in, to use these papers. So again, once again, thank you very much.
Thank you. So look, I think we're out of time, so let me just echo and add to the thanks. Let me thank the Georgetown University staff. If they could just stand up and wave. Let's give them a big round of applause. Betha, Ariana, everyone, thank you. The Lancet again, the tech staff and our interpreters, thank you very much. The conference organisers, and let me also thank you, ladies and gentlemen, in advance, on behalf of the patients and people that will benefit from your efforts, from the things that you will take care, the things that you will do differently. Thank you for coming, thank you for absorbing. If I can call Peter to the stage, and we'll just take one group photo, and then I think we are done for today, and I wish you a very good day. Thank you very much. Please, ladies and gentlemen, let's take a big family photo. Let's get a bit tighter. Yeah, family. Good side?
Thanks so much. Really, great seeing you as well. I mean, the question about